Thank you very much for the kind introduction and for having me here. I also like to thank Dr. Medina for hosting me over these days. Um, so I was asked to talk about clinical and imaging characteristics of Chagas cardiomyopathy, and these are some of my disclosures. Now, a few disclaimers. Now, I'm not an imager. I'm not an infectologist. I'm just a simple clinical trialist and an electrophysiologist. So, what I want to go over today in the next 45 minutes or so is a little bit on Chagas 101, give you a little bit of an introduction on Chagas, about the clinical manifestations and treatment, and the role of imaging in the diagnosis and risk stratification. Any guess on who's this guy? Nobody knows? Wild guess? Well, this is Charles Darwin. And why Charles Darwin? Well, there's a big discussion still about the fact that maybe Darwin died of Chagas cardiomyopathy. And Darwin describes very clearly when he was on the Beagle and in his journal, The Voyage of the Beagle, when he was in Chile about the triatoma and the kissing bug. And he wrote that at night I experienced an attack, for it deserves no less name, of the benchuca, a species of ridivirus of great black bug of the pampas. It is most disgusting to feel soft wingless insects about 1 inch long crawling over one's body. Before sucking, they are quite thin, but afterwards they become round and bloated with blood. And in this state, they're easily crushed. So apparently, Darwin was bitten by the retivirus, the triatomite that transmits Chagas, but we'll never know if he actually had Chagas cardiomyopathy or not. Matter of fact, the first cases of Chagas date 9,000 years ago, and they were described in mummies from the Incas. When they found some of these mummies that had megacolon, they did some DNA testing, and they found the DNA of the Chagas, of the Trypanosoma cruzi. So it's an old disease. So Chagas has been a worldwide distribution because of migration patterns. And you can see that the endemic countries are Mexico down to South America. And in the US, there's a significant amount of Chagas. And the bug is also kind of migrated, if you believe or not, in global warming. And there's some evidence of autochthonous Chagas disease in the States. And this is one of the most recent maps. This was published in Transfusion a couple of years ago. And you can see the number of cases reported. Texas leads the way of, these are autochthonous cases. In other words, bugs that have been found in Texas that have transmitted the T. cruzi. And this is the map. Basically, half of the United States has reported cases of blood transfused infection of T. cruzi. So you guys have Chagas here. It's probably broadly underdiagnosed, but it's still around here. Now, does everyone from Latin America needs to be tested for Chagas if you're going to donate blood? Well, it depends really on where you come from, and depending of the prevalence of a estimated T. cruzi, depending on your country of origin. And there's Bolivia is not here, but Bolivia, depending on the part of Bolivia, it's about a 22 to 30% of the population in Bolivia are T. cruzi positive. So if you have someone from Bolivia, Ecuador, some parts of Colombia, Venezuela, probably it's worth getting a serology. And you can see here the prevalence about 6% in Bolivia. And this is in the United States of the prevalence of infections. And so if you look at all these migration patterns, there's estimated about 5.5 million people may have T. cruzi positive in the United States. So how many of these immigrants really have T. cruzi? Well, we don't know, and it depends on the population. Latest numbers of Hispanics in the United States is 64 million people. Now, not all of these are migrants. Some of them are born here in the United States, so you have to keep that in mind. Now, Chagas is a fascinating disease. It has an acute phase and a chronic phase. And the acute phase is usually like a little flu or a cold. 90% of the time, it's not even diagnosed, but it has a high parasite burden with acute myocarditis in about 5% and some increase in cytokines that are quite typical. Now, the interesting thing is that about 20 or 30 years pass until, only 20 to 30% actually go into the chronic stage of Chagas disease, in which there is some partial parasite control, but there's a persistent low-grade parasite embedded both in the heart and in other organs. And this apparently is what triggers a lot of the immune response with inflammatory cytokines. And this takes the patient into the phase B1 and B2, which is what we call the indeterminate stage, which are patients that have a positive serology but don't have overt clinical cardiomyopathy. And then phase C and D, there's some myocardial damage, and there's some regulatory cytokines that actually trigger some myocardial repair. There's lots of inflammation. And then there's this ventricular dysfunction, refractory heart failure, and sudden cardiac death that occur frequently in people that have a normal LV function and that are younger than what we see in other patients. And this is from a paper we just published from the Parachute heart failure trial that I'm not going to discuss too much today. This is a randomized trial of sacubitril valsartan versus enalapril in Chagas cardiomyopathy. We just finished enrollment in Brazil, Colombia, Mexico, Argentina of 1,000 patients. And I just got an email today that we already have basically all the events that we needed. So this is going to probably be presented at the ESC next year. So stay tuned. And again, as mentioned, only 20 to 30% takes about 20 years. So that's one of the challenges that, anything we test in the determinate stage, we have to wait 20 to 30 years to know if it really worked or not. So that's where imaging and other things that we're using becomes quite useful. And again, this is from the AHA paper that we published a couple of years ago on Chagas. It has some very characteristic cardiac rhythm disorders with sinus node dysfunction, AV block, bundle branch block, and typically right bundle with left anterior fascicular block. That was described by Dr. Rosenbaum in Argentina 60 years ago. VT and VF are quite frequent. Atrial fibrillation, matter of fact, stroke may be one of the primary initial clinical abnormalities that you see. And there's several myocardial abnormalities like segmental wall abnormalities, global wall motion abnormalities with severe dilated cardiomyopathy as shown over here, and then lots of aneurysms, as I will discuss in the next few slides. So symptomatic patients, really, there's not a lot of evidence-based medicine on the treatment of these patients. We don't know if ACE inhibitors work, beta blockers. There's a lot of resistance to using beta blockers because Chagas cardiomyopathy and Chagas heart failure clinically usually presents with bradycardia. So, and these patients usually have AV block, so beta blockers have not been used that intensely in this population. And we also know that, these patients have some important predominance of CDH and T cell subpopulations in different areas of the heart, particularly in these aneurysms that you see around different areas. So Chagas disease, again, has two phases. The acute phase lasts about 2 months, a little bit of fever, usually transmitted by the vector. There's also congenital transmission, and there's been some oral transmission that is rare, but it's been reported. And, again, these patients may have acute myocarditis, megaesophagus and megacolon can be seen, but it depends on the type of T. cruzi. There's 5 distinct DTUs, discrete types of units that make it very difficult to diagnose. And again, there's reactivation when there's co-infection or when these patients are being treated or immunosuppressed for transplant, they get reactivation of the parasite and then they end up having acute Chagas. And again, the typical right bundle with left fascicular block. It's not pathognomonic, but it should make you think about a potential Chagas cardiomyopathy. Now, what about the treatment? Now, the treatment has been in a lot of discussion whether we should get rid of the parasite or not. And as I mentioned and showed on the pathophysiology, well, the parasite and that low-grade parasitic persistent infection does trigger this inflammatory immune response. And there's been findings of T. cruzi in very chronic patients. So there was a thought that maybe antiparasitic treatment would be worth it. And there was this big debate of whether we should treat these patients or not. So we did some initial trials, and this is in the indeterminate stage. This was what we call the STOP Chagas trial. little bit of a presumptive title, but anyways, it's catchy. Things that you have to learn when you create an acronym for a trial is get a catchy name. So otherwise, nobody's going to cite it. But anyway, so we tried bisnidazole, which has been the molecule has been around, the standard for care of the antiparasitic response, and posaconazole, which is an azole that had been reported to be possibly effective in this type of population. Again, these are patients in the indeterminate stage, means that they don't have any ECG changes. Echo is normal. This is usually a very young population. You can see that the mean age in this population is under 40 years. Relatively lean people, came from Argentina, Chile, Colombia, Guatemala, Mexico, and a non-endemic country like Spain. So this is a study that actually included those. A small clinical trial, but it was double-blind and also with placebo. And the primary outcome was to look at the PCR that looks at the DNA, circulating DNA of the parasite. And you can see here that, once we treated these patients with the blue one is posaconazole, treatment is usually 60 to 90 days. Then all of a sudden, the PCR became again positive, which means that the treatment failed as much as the placebo. And bisnidazole alone was really effective. So bottom line, and this is only a follow-up of 1 year in patients that have the indeterminate stage, which means that we don't know if this is going to prevent the cardiomyopathy, but at least there's significant clearance of the parasite. And we've done some meta-analysis looking at fixed doses or not, and it seems to work both quite well. And then we did the benefit trial. Now, the benefit trial was a trial that was funded by the CIHR, the Canadian NIH, and by the TDR, which the Tropical Disease Research Branch of the WHO, and some money from the Wellcome Trust. And we published this almost a decade ago. It took me almost a decade to do this trial. And this trial was a randomized clinical trial of patients that had chronic Chagas cardiomyopathy, that had to have some positive serologies, ECG abnormalities, and some baseline echo abnormalities. And we randomized patients to bisnidazole, which was the standard of care, against placebo. And again, this was a study that we conducted in Brazil, Colombia, Argentina, El Salvador, Bolivia. And again, it took us almost 10 years to conduct the study and get almost 3,000 patients. But the fact was that we were in the middle of the study, so the drug was produced by Roche. And in the middle of the trial, Roche told us, you know what, we're not producing any more bisnidazole because who cares about Chagas, and nobody pays anything for that. Bisnidazole is about $1 the treatment for 90 days. So in the middle of the trial, I had to stop the trial because I had no drug or placebo. And we had to go to the Brazilian government, convince the Brazilian government to get some company there to produce the drug, get some really fast PK done to bioequivalence, and restart the trial. So it was a lot of my gray hair came from that trial, but well, we ended up doing it. We had a mean follow-up of about 5.4 years with a primary outcome that was composed of hard outcomes like death, resuscitated cardiac arrest, and you can read the other ones there. So it was a little bit older population, but again, the majority of these patients were in class 1 and 2 New York Heart Association. About 14% had pacemakers, very low usage of implantable defibrillators way back then, and a significant proportion with atrial fibrillation, about 7% or so. And with what was standard care for heart failure, which was not that good back then, but you can see that, beta blockers only about 30% of the patients, with ACE inhibitors, 50%, and spironolactone, about 16%. But about 20% were on amiodarone way back then. Now, what we were looking was at both PCR conversion, and you can see here that the overall conversion at the end of treatment, that was 90 days, was quite significant, almost 70%. But after 5 years, this kept dropping. But one interesting thing that we saw was that if you see here is Brazil, and this is Colombia and El Salvador, and then Argentina, the response was very different. So why was that? Now, there's a bunch of theories that we had, but then we realized that what happens is that there's 5 different types of T cruci. And the T cruci varies depending on the country in which you are. And as a matter of fact, in Brazil, that's just such a big and large country, there's 2 or 3 different T crucis. And so maybe the effectiveness of the treatment didn't work that well. And the other thing is that, of course, as cardiologists, we just gave a treatment for 90 days and we thought that's going to work. But, we didn't think as infectologists, like, if you look at leprosy or TB, people get treatment for years before you clear out the parasite or whatever bug you're trying to clear out. So maybe that was one of the faults of the design of the benefit trial. And you can see here the Kaplan-Meier curves at 7 years, where there was no difference in the primary outcome. So that created a lot of discomfort among some of my colleagues in the different countries. And you can see that there was no difference in the subgroups, but there was only one subgroup in which there was some significance for interaction, was the amiodarone group. Now, was this chance, or is there any rationale that people on amiodarone would do better than those that did not receive amiodarone? And interestingly enough, amiodarone is a drug that actually has, it inhibits the trypanosoma cruzi. And it also has electrophysiologic properties that, in combination with inhibiting the T cruzi, reduces arrhythmias and may potentially be something that works in combination with benitazole. So we did some further analysis of the benefit trial, and it seemed like that's one of the reasons why this worked. Now, again, there's a great discussion. Again, doing clinical trials is a complicated thing, and I'll tell a little bit of a story on this sub-analysis. So it's been 10 years after that, so I can tell the story. But the fact was that, so the guys from Brazil insisted that this drug worked. And without telling us in McMaster, so the other main investigator of this was Dr. Salim Yusuf, that you probably all know, big clinical trialist. And then suddenly I get a phone call from some of my friends in Brazil and I said, hey, they just published a sub-analysis from the benefit trial. Do you know about it? I said, no. How do I know? They don't have the database, so how did they get the data? So anyways, the fact was that, I had to call my guys in Brazil and tell them, hey, what's going on? Well, we think that this works here and that, the trial was positive. Like, the trial was negative. What are you talking about? Anyways, we had to go back, look at the database, and you see that there's like a separation of the Kaplan-Meier curves here for Brazil, but it's still not a positive trial. So again, maybe we should do the benefit 2 trial, but by the time I finish it, I'm probably dead or demented. So I don't know if I'm going to do that anymore. Anyways, here's some updated estimates and who should be treated. So we think that the people in the chronic stage probably don't need treatment. And I may show you some exceptions later on. Now, again, imaging. Imaging comes in pretty handy in Chagas. As you know, there's significant fibrosis with significant alterations like this one here, big aneurysm of the apical area, also aneurysms in the inferior basal area. Now, why is there aneurysms in the inferior basal area and in the apex? Well, a gazillion years ago, I think it was in the late 80s, Doug Zipes did a very nice study on animals, and he showed the innervation of endoepicardium of the autonomic nervous system, both the vagal and sympathetic. And there's a very differential innervation at the apex and the inferior basal area. And remember that, the basal-gyrix reflex, those mechanoreceptors are at the inferior basal area. So that may be why, because the bug and the T cruci is very avid of that kind of tissue, maybe why that happens there. And there's some stuff that actually Dr. Medina here has reported previously. And MRI, beautiful images, but the problem is that, you can't get MRI on everybody in South America, so need to do other things. So echo and looking at GLS seems to be quite effective. And you see these are some images that one of my colleagues in Colombia, in which I collaborate quite a bit, has provided me. Again, I'm not an imager, but I can even see that there's a huge aneurysm there, and there's some wall motion abnormalities. And, there's other macro aneurysms that you can see primarily in the apex and some in the inferior basal area, which can be nicely detected by echocardiography, and microaneurysms that you can see also this one over here, an MRI nicely seen, and an echo also very nicely documented, and maybe something in inferior posterior basal area there. So echocardiography seems to be quite useful, and segmental wall motion abnormalities are also quite characteristic, as you can see here. And we've done some further studies on this, and I'll show you some of the data from the benefit trial. The AHA and the American Society of Echocardiography has provided some recommendations on when to do echo in these patients and what to look for. Because a lot of these patients may come to your labs, and if you don't ask for the origin of the patient, or if they come from a prevalent area of epidemiologically, you may miss the diagnosis of that. And it's also pretty good to stage the disease, and the stages like similar to what we use in heart failure. And in stage A and B, which about 30% actually already have early echocardiographic alterations that can be detected by GLS. And we've done some studies looking both at brain natriuretic peptides and in the indeterminate stage. And we've seen that there's a significant proportion of these patients that about 30% will have some alterations. We've looked at other biomarkers like SLG, LV, myocardial emotion, E velocity and proBNP, and there's already some early changes that can be detected in this population. We don't know is should we be treating these patients either with more antiparasitic drugs or some other forms of therapy. I was thinking what would be my next trial to do. And I think at the AHA, there was this interesting study in which they showed that sacubitril valsartan could prevent some of the cardiotoxicity. And maybe if we use that and repurpose it in patients in the indeterminate stage, we can prevent some of the progression of the disease. And we've been able to show that with some of these echo markers, as well as proBNP, we have a very high sensitivity and specificity of predicting those in the indeterminate stage that already have early cardiomyopathy. So probably intervening at those early stages and simply showing here some other different types of biomarkers that included CIS-C and other GAL3, for example, which is a repair protein, also seem to be important. And we've looked at also diastolic dysfunction in combination with echo, and you can see that we can actually risk stratify these patients quite nicely. So we're trying to look into this with AI and machine learning to see if we can be able to predict more and earlier these patients and intervene them a little bit earlier. And again, more of the same with looking at multivariable analysis, in which we've looked at LV function, global longitudinal strain, and EA ratio in this population that seems to show that we can early on identify these patients that are going to have events, and these events are basically death, sudden cardiac death, need for transplant, or heart failure admissions. So again, small series, about 300 patients that we've seen mostly in Bucaramanga in Colombia, but these patients actually have a very nice progression of the disease when they have only one of these markers present. It's about 10% will have one of these outcomes that I'd mentioned. Again, death, heart failure, sudden cardiac death. When you have two, you've got about 30% that have that. And when you have three of these markers, almost 60% are going to have one of these cardiac outcomes within 1 year. So we've been able to actually identify this population, at least with imaging early on, which is also shown here in the Kaplan-Meier curves. So if you have, a patient that has three of these, by 5 years, almost 50% are either dead or have had already one of these events. So I think that with this, we can identify the population that will benefit from these interventions. And again, the guidelines, this is from the Brazilian Society, recommend that, we use these guidelines for these patients. Other things that, we've been using, and this is from a Brazilian group, has looked at mechanical dispersion. And mechanical dispersion actually correlates quite nicely with dispersion of refractoriness, which is what creates basically VT-VF. And there's some pretty good sensitivity and specificity, over 90% in this small series. And this is some data that's still not published from the group in Colombia, that I collaborate. This is from Dr. Cheveri also, looking at prediction of non-sustained VT and sustained VT with some cutoffs that are shown there. And at 89 milliseconds, you can see that there is a high proportion of these patients. And we did a little score. And when you have a mechanical dispersion greater than 75 milliseconds, you almost have a 2.5-fold odds ratio of having VT in the next year. So that's quite powerful, and hopefully, will guide us to therapy to those patients, because there's still a lot of discussion whether these patients benefit or not from defibrillators, and I'll show you some recent data on that. And again, if you have greater than 3 points, you're about a 30% risk of non-sustained ventricular tachycardia and an event of probably sudden cardiac death within the next year or so. So these data kind of help us stratify this population using imaging quite nicely. Now, from the benefit trial, we had these 2,840 patients. We had a core lab. Everybody had a baseline echo at 6 months, and an echo at 5 years. And we looked at the primary outcomes. Remember that the primary outcome was a composite of death, VT, heart failure, et cetera. And you can see here, if you had wall motion index greater than 1 at baseline, at 6 years, pretty much 70% of the population had one of those outcomes, and about 50% were dead by 5 years or so. So this is a population that does really, really poorly. So identifying these patients with something simple like echo, and with this index, you do some machine learning, that could actually help. Now, beautiful images from Hector here with its Chagas and MRI. But the problem is the MRI is not that easily available in South America. And, usually patients with Chagas are poor and they don't have any heart insurance, any health insurance. One of the interesting things about Chagas is if you look at the coronary arteries, these people usually, 90% of the time, they have very clean, big ectatic coronary arteries with slow flow, but no lesions inside. But they have their characteristic alterations in LGE that you see here. And this is a male-female study, because being male has been shown to be a risk factor for higher outcomes in this population. And you can see that they have higher mid-wall, higher subepicardial, and higher transmural LGE percentage of segments compared to women. And this may be one of the reasons why this leads to further worse outcomes. And again, the typical characteristics are subendocardial, about 13%, mid-wall, 32%, and transmural, about 44%. Again, this is data that Hector has published prior. And these are the different studies that have tried to look at the different areas that are affected in different studies. And you can see that it's pretty much all over the place. But there's a significant proportion of patients that have significant fibrosis based on this. And this has been used to try to identify populations that are going to have risk of sustained ventricular tachycardia or cardiovascular death. And you can see here that about 60 months of about 25% are going to have an event if you have LGE positive. And some have looked at the proportion of mass that is affected that may be part of the myocardial fibrosis extent. Here, there's another series that looks at that. And again, quite easily and good discriminator of looking at the combined endpoint that included sudden cardiac death in this population. But again, unfortunately, this is not that easy to do. T1 mapping actually looks at inflammation and other issues within the heart, but it's been correlated with VT, and it has a pretty good discrimination capacity. And you can see from this study published recently, even in patients in the indeterminate stage, in this study that was not that big, in about 114 patients, they didn't have any events, but if you progress throughout the disease, with reduced ejection fraction, about 40% are going to need an ICD, and about 12% die within 2 years. So rapid progression. And again, this prospective study shows some interesting things, like if you look at the extracellular volume values, greater than 30% were present in about 12% of the patients that supposedly don't have any cardiomyopathy. So that could be an early marker of patients that should probably needs some further therapy and what kind of therapy that's to be discussed. Here's a meta-analysis we just published recently in JACC Cardiovascular Imaging, looking at all the different series, and you see that there's about a 46% that have a greater than 40% segments with LGE, and these had a high proportion of risk of VT and other cardiovascular outcomes that included heart failure and death. So definitely it's a good marker, but hopefully we can find better markers to identify these VTs and sudden cardiac death. And again, as you know, sudden cardiac death is quite prevalent in this population. And the problem is how to identify these populations earlier. And, of course, MRI reconstruction, and this is part of what we do to try to find the VT circuits and get rid of them. And, very nice imaging here from the group in Brazil at the INCOR. But again, this is not readily available. And again, this is the Chagas trial. It was just published recently in JAMA Cardiology. This trial basically was a randomized clinical trial of about almost 400 patients. They were allocated to amiodarone or ICD for primary prevention. And unfortunately, again, these are difficult trials to conduct. This trial was terminated early due to futility because it didn't show any difference between the primary outcome, which is all-cause mortality. But again, as expected and what's been seen, like for example, in the Danish trial, there's more than almost an 80% reduction in sudden cardiac death, which is what you expect the defibrillator would do. But again, this trial was terminated because of futility. So still work in progress. And they also had some interesting reduction in heart failure, but it took over about a year to see the effect there. Now, again, I started getting interested in Chagas because of the autonomic function, and we were able to identify some clinical Chagas by doing a serial testing of the autonomic function in these patients. And we're also able to predict using nonlinear dynamics. This was a long time ago. I think, when was this? In the early 2000s, we published this back in the American Heart Journal. We were looking at the defibrillators and looked at all the VTs and did some nonlinear dynamic analysis. We're able to predict patients that were going to have VT and VF storms earlier on. They also had some other autonomic alterations. So there's been some studies that have looked at the extent of myocardial sympathetic denervations that did not have myocardial fibrosis. And they've been able to identify that these patients with altered MIBG have a higher risk of VT and VF. So they looked at both myocardial perfusion. Oops, this is going faster than what I want. So looking at myocardial perfusion, cardiac MIBG, and myocardial innervation, and there was a strong correlation between myocardial innervation and perfusion mismatch and the risk of about 20% risk of sustained ventricular tachycardia and even non-sustained ventricular tachycardia, about 10% in that population. And this is usually in the inferior basal and apical regions. And again, another interesting fact is that, we see these patients that come with storms. I've had patients with Chagas that come with 120 shocks in one day. So that's a total nightmare. But if you look at PET and you look at other forms of looking at inflammation, there's like acute inflammatory response in those patients. So why is that? Is the parasite being reactivated and you need to treat the parasite at that point in time? And we've done some studies in which we've actually given acute antiparasitic treatment in these patients, and you can actually reduce the number of shocks in the VT storm in this population. So PET may be useful in predicting ventricular arrhythmias in these patients, and also the appearance of patients that are going to have VT storms, as you can see by looking at this mismatch between perfusion and MIBG and LGE, which has been reported by some groups in Brazil. So there's fibrosis, inflammation, and autonomic dysfunction, and all this comes together and leads to storms and sudden cardiac death. So probably intervening earlier and also a combination therapy there may be of use. And furthermore, this recently also published at the end of last year, looking at perfusion abnormalities in the early stages. So in patients that don't have a myocardial hyperperfusion and fibrosis, but that are in the early stages of Chagas, and they have this mismatch between innervation and perfusion that may trigger these arrhythmias and that may be the leading cause in patients that are in the indeterminate stage that will later progress to the stage with VT and VF. So this is the parameters that you can detect, and there's a bunch of them. I'm not going to read them all to you. You can read them, and both with nuclear cardiology, magnetic resonance, and echo, and this little algorithm that's been proposed recently. And what do you do with these patients? If you have Chagas that's been confirmed, you get your echo, your ECG, and you look if whether it's normal or not. You may want to get an MIBG to determine whether it has early Chagas cardiomyopathy or not. And based on this, you may determine the course of therapy or the course of intervention. Now, we've been trying to understand this disease a little bit more. This is a complex diagram, but we've been looking at metabolomic profile of end-staging heart failure that is secondary to Chagas. And part of what we're proposing is that maybe we need to work on designing drugs that tackle some of these pathways so we can prevent the progression early on of the disease. And again, as you can see, there's some parasite control, but there's still parasite persistence that is going to lead to tissue damage and all this cascade of abnormalities. So we think that if we actually act at some of these areas, so a combination, so something like a poly pill for Chagas. What is that poly pill going to contain? Something that contains the inflammatory response, something that gets rid of the parasite, and something that also controls arrhythmia. So a poly pill with a little bit of amiodarone, some bisnidazole, maybe an ANK inhibitor or some kind of cytokine inhibitor. And we're doing some experimental stuff that I still don't have any data on an animal model, but hopefully that may lead to understanding a little bit better the molecular mechanisms and trying to stop Chagas disease. So just paraphrasing Gabriel Garcia Marquez, it's been about 115 years of solitude in the development and research of Chagas. Now we've advanced quite a bit, but we're still way behind on the development of drugs. Very few companies are interested in designing or developing drugs. Fortunately, the Novartis Foundation has 3 new compounds that we are testing in an experimental model. And again, understanding the pathophysiology and detecting those patients that are in an indeterminate stage, which is the largest population right now anywhere in the United States and all around the world that could merit some form of treatment, is worth taking a go. So in conclusion, Chagas disease is in North America and it's grossly underdiagnosed. Using multimodality imaging is very important for diagnosis. And actually, every week I get a call from someone in the US and tells me, hey, what do you think about this ECG and this MRI and this echo that you say, well, where does the patient come from? Bolivia. Well, it's got Chagas, man. What do you think? And then, Chagas, what are you talking about? Last week it was Boston. The week before it was New York City. So you guys probably have way more of these patients that you're not making the diagnosis. The other thing is that there may be people that were born here in North America, but the mother was a carrier and she was never tested. And the patient was never tested. And that guy, I can assure you, if the mother came from Bolivia, probably has a 30% chance of having a positive serology. And if he shows up with VT and, a VT storm or something, well, think about Chagas. So again, you can't do anything without the collaboration of the institutions where you work. And this one is the Heart Institute in Columbia, where I did some of the initial work. There's the PHRI at McMaster, and this is Calgary. And this is all the list of people that have helped me out throughout the days to create and develop this line of research. Now, again, I probably see a patient with Chagas once a month that gets referred to Calgary. People don't like coming to Calgary, especially this time of the year. When I left Calgary yesterday, it was minus 20 degrees. And we had like 2 feet of snow. But this is Banff in the summer. So happy, thank you very much, and happy to take any questions you got any.